So next we have Dr. Nick Abreu, who's going to talk about the neurological manifestations of Fabry. And can we have Dr. Abreu's slides up? Okay. Dr. Nicolas Abreu received his BS from Yale College and MD from Harvard Medical School. He then trained in pediatrics at NYU Grossman School of Medicine and neurodevelopmental disabilities at Boston Children's Hospital / Harvard Medical School. He received his fellowship training in gene therapy at Nationwide Children's Hospital in Columbus, Ohio. Dr. Abreu is an assistant professor of neurology at NYU Grossman School of Medicine in New York City. He serves as the director of the Vibrant NYU Lysosomal Storage Disease Disorders Program, providing comprehensive care to children and adults living with lysosomal storage disorders, including Fabry disease. He also serves as an associate director of the Division of Neurogenetics. His research portfolio spans natural history studies, registries, outcome measures, and biomarker development, as well as precision therapy, clinical trials in neurogenetic and lysosomal storage disorders. He currently serves on the Patient Outreach Committee for an American Society of Gene and Cell Therapy and the Scientific Advisory Board for the TANGO2 Research Foundation. So also, I didn't mention before, but Dr. Rob Hopkin and Dr. Eric Wallace, and now Dr. Abreu has joined our medical advisory board, which you'll hear more from us about that before too long. Welcome, Dr. Abreu.
Hello, and thank you for having me. Delighted to speak. I'm a child neurologist and neurodevelopmental disability specialist by training, focusing on genetic disorders that affect the nervous system and also provide management for lysosomal storage disorders. So here are my disclosures. We'll create a broad overview about the neurology of Fabry disease, looking at both the central nervous system and the peripheral nervous system, taking a four-box approach, looking at the features of specific aspects of neurologic problems in Fabry disease, then looking at how do we assess or diagnose these specific issues, looking at who should be on your team if these issues are a problem, and how can we manage it. When we think of the nervous system, we can think about the brain and spinal cord that defines the quote-unquote central nervous system, but then you have your peripheral nerves, neuromuscular junction, and muscles, of which the peripheral nervous system is also affected in Fabry disease. And so for central nervous system involvement, we can think about strokes and vascular disease, as well as cognition and mood. And for the peripheral nervous system, we'll talk about neuropathy and pain, differences in sweating, or autonomic nervous system involvement, as well as problems with the GI tract, although I'm not a GI doctor, as well as issues with the 8th cranial nerve, hearing, and vertigo. So here's some of the take-home first for children, thinking about nervous system involvement in terms of vascular disease. In terms of most common routine assessment is through brain imaging, which the most common, which does not expose radiation to a child, is through brain MRI. Typically, this is only done in children less than 18 if there's a specific reason to get imaging, not for routine surveillance. And oftentimes, if there is concern for vascular disease in children with Fabry disease, a child neurologist or potentially a pediatric hematologist may need to be on board. Oftentimes, if a stroke in a young individual is identified, it's about managing modifiable risk factors, especially seeing if there's any reason for clotting in addition to Fabry disease that may be going on. And also, if a stroke is identified, things about medications to prevent a stroke in the future could be considered. For cognition and mood in children, oftentimes this is relying on school and school-based evaluations, and also potentially office-based evaluations if there are concerns. And there's a panoply of different specialists that can be involved, including school and on a clinical basis. For neuropathic pain, there are a number of pain scales that are now in development, including for children, that can be routinely administered in clinic to help identify what's going on and how severe or how frequent pain episodes are. And oftentimes a pain specialist who can be trained by rehab medicine or through anesthesiology, but then has a clinic-based practice can be helpful, or a child neurologist can be involved. And oftentimes, creating a pain action and prevention plan can be very helpful for families so that they know in urgent settings as well as on a day-to-day management home-based plan, everyone is in agreement about what to do. Differences in sweating oftentimes can lead to pain episodes, but both as already talked about, too much sweating or too little sweating can be an issue, and certainly in settings of too much sweating, sometimes seeing a pediatric dermatologist may be needed to talk about prescription strength type antiperspirants, but really managing triggers and is the most important thing. For issues with GI problems, there's a range of things that we need to consider on routine visits with your Fabry specialist, and oftentimes an additional support through a GI doctor and or a dietitian, thinking about both behavioral and nutrition support services as well as medications or additional diagnostic tests if to rule out any other conditions not related to Fabry disease may be needed. And then hearing in children, some people may recommend baseline screening for all children diagnosed with Fabry disease. It's less common, so ultimately unclear if routine audiological assessment separate from your routine primary care visits may be needed, but oftentimes an audiologist and a pediatric ENT specialist could be helpful, and then making sure that school-based accommodations, medical devices, or medications are used. For adults, the current recommendations for 2018, which are really based upon like anecdotal recommendations, is for brain MRI for about every 3 years for men greater than 21 years of age, and for women 30 years of age and older. And there should be, in addition to brain imaging, checking blood vessels, since there can be buildup of the blood vessels around the brain leading to narrowing, that can better assess risk for stroke in the future. And then in some cases, a CAT scan, which is faster but not as detailed as an MRI, can be used in specific cases. Sometimes a stroke-specific neurologist or vascular neurologist can be helpful, especially in people who've already had a stroke. And managing strokes include modifiable risk factors and prevention measures as is the case in children. For cognition and mood, both work and office-based evaluations may be available to a number of individuals, and making sure that we're on top of these concerns, as well as neuropathic pain similar to children, differences in sweating, and then problems with stomach and bowels and hearing, at least in hearing in adults, at least a baseline evaluation is generally recommended for adults. So going into stroke and vascular disease of the brain, wanted to define some terms. So stroke is the sudden loss of blood flow to the brain. It can be due to blockage or a little clot or some pieces shown on the right here. Or it can be due to bleeding. So sometimes in people with high blood pressure, they may be prone to having bleeding in the brain that also causes loss of blood flow. We can help distinguish between the two with brain imaging, but it's really important when identifying if someone does have a stroke, what kind of a stroke it is. Is it related to blockage or to bleeding? A TIA, or transient ischemic attack, is this temporary loss of blood flow to the brain, but then is ultimately restored. And so someone may have all the symptoms of a stroke, with slurred speech, weakness on one part of the body, And ultimately, that is sudden in onset and lasts only for 30 minutes and then recovers and never has anything detected on MRI. And if in a good collection of a history, it really seems sudden in onset with all these features without any other issues going on, sometimes a TIA can then be diagnosed. The risk of stroke in Fabry disease is higher than the general population and does increase over time. Somewhere between 11% of men and 8% of women appear to have some stroke. We heard cases about stroke happening in very young children, but in general, the mean of onset of stroke is somewhere between 30s to 50 years of age. And there are risk factors separate from Fabry disease that may increase someone's risk of stroke, including smoking, overweight status, lack of physical exercise, dyslipidemia or high cholesterol, and high blood pressure. And so those are ones that when a stroke is identified, or even in terms of primary prevention, that we're aggressive in terms of trying to manage. Why does stroke happen? It's complex, and so there's discussion about the storage material, GB3 or GL3, that can build up in the lining of the blood vessels in the brain that may predispose to clot formation. There's also changes in the clot components that in the setting of, for example, having heart disease or related to friction, other issues that the components of the blood itself that may predispose to forming clots. And then the blood flow patterns, especially with abnormal blood flow due to existing heart disease and or kidney disease, all these factors together may increase the likelihood of a stroke happening. And so ultimately, brain health is dependent on heart health as well as kidney health. What do we need to look out for stroke? Think fast is really the routine way that we try to recognize stroke in the community. And so that's looking for face drooping on one part of the body drooping, arm weakness or numbness, and typically asking someone to raise both their hands if you're concerned, and seeing if one just doesn't raise as quickly as the other, looking for slurred speech or speech difficulty, and then calling 911. There are other stroke symptoms, and so sudden onset numbness, especially on a whole part of the body, confusion, or even sudden trouble seeing, as Dr. Hopkin mentioned in the young adult that he saw, difficulty walking or sudden onset imbalance, and a severe or thunderclap headache are all other less common but certainly concerning signs. Why is it important to call 911? Because time is brain, and ultimately our treatments are totally dependent on how fast stroke can be recognized and ultimately diagnosed. So in individuals who have a stroke due to loss of blood flow or a blood clot, we're able to give a certain kind of medication called TPA or IV alteplase as long as the stroke, as long as the last known well time is within 4.5 hours. And so we're really close on stroke calls, making sure that we know exactly when the time the person was last known to be within their normal state of health, and that really is the time by which we determine, okay, is someone actually a candidate for urgent therapy? There's also ways to actually go within the blood vessels to try to remove clot if a clot is identified, and that has a longer window of 24 hours, but certainly only certain people who have certain findings on imaging are candidates for. Ultimately, urgent brain imaging is very helpful if there's a concern for stroke, and typically most hospitals should have a stroke code so that people, as soon as they're recognized in the emergency room, go to the CAT scanner, at least for adults, as soon as possible. And oftentimes it includes not only images of the brain, but also the blood vessels, really to see if there's any blockage or clot that could be removed or treated. One big aspect of stroke care is the difference between primary prevention and secondary prevention. Primary prevention is in those who have, say, for example, Fabry disease, but have never had a stroke before. How do we manage their risk for further stroke? In general, at least my understanding is that there's no clear guidance about the routine use of aspirin or antiplatelet agents routinely, in contrast to secondary prevention, where these types of agents, as well as anticoagulation in very specific cases, especially, for example, in atrial fibrillation, medications may be used. And then clearly, modifiable risk factors are always critical in terms of ongoing stroke prevention. Here's an image of what we see on brain MRI. These are slices through the brain, or axial slices starting from the top, going down the bottom. At the top of the screen is like where someone's eyes are, and the back of the head is at the bottom of the screen. And so these are going from top to bottom, and you can see these spots. They're called white matter hyperintensities because what we call bright on MRI on certain sequences are called hyperintensities. It's just nomenclature. And so these bright spots are what we see when we're reviewing these MRIs. Now, we see them in a lot of other conditions besides Fabry disease, but yes, sometimes they can be mislabeled because they're so prominent as concern for multiple sclerosis or other genetic white matter disorders. Sometimes they can just be single, or they can be more extensive, like in this case here. They seem to increase over with age and may be associated with other kinds of risk factors like smoking or significant heart disease. And it's unclear if these have any clinical significance. When we do routine brain imaging, it's oftentimes to see if there's new strokes that we somehow didn't catch, and really trying to identify silent strokes or changes on MRI that don't always cause symptoms. But in so doing, oftentimes when we're repeating these imaging, we can see changes in this white matter, the disease burden, that is hard, at least as a clinician, to then counsel individuals about what does this actually mean. And ultimately, it's unclear. So we talked a bit about screening recommendations for adults. In general, recommended every 3 years in certain populations. That primary prevention for stroke is really about managing modifiable risk factors. And for secondary prevention, sometimes daily medications, either antithrombotic or antiplatelet agents may be helpful. And ultimately, for Fabry-specific therapies, whether it's enzyme replacement therapy or chaperone therapy, may reduce stroke risk, but there's limitations in the existing studies. Hopefully, with long-term data, we have more information about the utility of these treatments. So cognition and mood, ultimately, cognition so far has focused on looking at information processing speed as well as executive functioning, potentially abnormal in either children or adults affected in Fabry disease. There's some concern, especially with for individuals who have multiple strokes or significant vascular disease over time. In older age, there may be an association with cognitive decline, but that is much less common and is more so associated with those with classic disease, if at all. But depression really affects many individuals with Fabry disease, regardless of genotype or their genetic change or their sex. And so 20 to 60% of people with Fabry disease may be affected with depression, and it's highly underdiagnosed and may be associated with things like chronic pain, quality of life, and relationship or financial status. And anxiety may co-occur. Just want to emphasize that depression really can happen to anyone, kids, adults, including caretakers for or loved ones for an individual with Fabry disease, in addition to the individual or child. And symptoms can range from low energy, irritability, sleep changes, or difficulty in concentration. And oftentimes children may not show the classic signs as adults with depression and may act out or be especially angry or aggressive and not have the typical low mood, depressed, slow movement that is seen in adults. And so ultimately making sure that if you're concerned, you raise concerns to the appropriate healthcare team members. There are screening forms as well as more detailed assessments. There are neuropsychological, psychological, or psychiatric evaluation that can be helpful. And for children, making sure that the school team is involved, whether it's a 504 or IEP formal evaluation, including a psychological evaluation, or even looking for opportunities through work or even a spiritual home to making sure that appropriate assessments and care is initiated. And then here are just a few websites online that are available for finding a mental health care provider. I also want to emphasize the Fabry Family Assistance Program that's free and amazing, that's offered, 24/7 short course counseling that's confidential, and is more information is available on the NFDF website. No one should be suffering alone, and no concern is too minor. And so any reason to seek out help should be done. So neuropathic pain, previously called acroparesthesias, now really we're saying is a small fiber neuropathy, or a problem with the very small fibers that control pain in our extremities. It affects as many as 60 to 70% of males and up to 60% of females with Fabry disease, and it certainly is reported in young children. It affects fingers, toes, palms, and soles, but definitely affects other areas, and some individuals have consistent chronic pain, others just have a few episodes, but it varies really from person to person and even within a given family tree. Pain certainly can be incapacitating, and triggers like physical exercise, heat exposure, fever, or alcohol in adults certainly can happen. And while episodes can last minutes, sometimes it can last several days, sometimes leading to absences from school, and may be associated with discomfort or pain even to light touch. And so this really hyperalgesia or allodynia is some words that we use to describe this really high degree of sensitivity. When looking at the mechanism and studying these nerves under a microscope, you can see that there's changes in some areas of the cell bodies of these nerves with the buildup of storage material from Fabry disease. And then you also see in the periphery, when you take small samples of skin, a reduction in a certain of these very small nerve fibers. There are typically, the way that this is assessed is through a good history taking from a Fabry specialist. There are ways to quantitate this through questionnaires. And on the right-hand side, you can see ways of doing quantitative sensory testing. It's generally not done routinely, though in some cases where it's a question about what the underlying diagnosis is, a skin biopsy can be used to look for this, the amount of nerve fiber density to really quantify small fiber neuropathy. There's a whole range of team members that can be involved for managing neuropathic pain, from neurology, a pain specialist, a rehab specialist, and certainly physical and occupational therapists to get someone who's quite disabled from pain back and going. And we'll talk a little bit more about a pain action plan. This is one that I pulled from the Canadian Sickle Cell Disease Action Plan, another genetic disorder that can cause chronic pain. And it provides a very nice approach, at least for children, to think about working with your healthcare professionals so that you have a pain plan. Sometimes it's just, how do we make sure that we assess it? This is hard to read, I understand, but in children 2 to 5, oftentimes they're not able to express their pain very well, so asking them to rate their pain on a 0 to 10 scale is nearly impossible, or if they do, you don't know if you're accurate. So using other measures like if they're less engaged with their routine activities, if they're refusing to eat, crying, and trying as a caregiver or loved one to assess their pain, having to use these measures and come up with a response is the next best step. Then for children 6 years and above, asking them to rate their pain on a 0 to 10 basis and monitoring that can be very helpful. And then creating an action plan or a treatment plan using medications for mild, moderate, or severe pain and working with your doctors to create medication A for mild pain, maybe A plus B for moderate pain, and then potentially adding a third medication or just trying something else for severe pain and making sure that you have an appropriate contact thereafter so that any acute persistent pain is adequately evaluated. Then making sure that you have a prevention plan, both for physical measures, so controlling heat exposure, for example, and then working on non-pharmacologic prevention or pain relief, whether it's mindfulness exercises or distraction technique, and then thinking about a daily preventative medication and Fabry-specific therapy. Differences in sweating largely boil down to problems with the autonomic nervous system. Seen on the right, sweating is related to the sympathetic division of the autonomic nervous system, which, since Fabry disease seems to affect nerves, is thought to be at least one aspect of why individuals with Fabry disease have changes in sweating, both absent or increased sweating, but there also seems to be buildup of storage material in sweat glands. Making sure that, in general, QSART testing is not a part of routine evaluation for sweat evaluation in individuals with Fabry disease, and a dermatologist can rarely be used. Mainly it's avoiding triggers. GI problems are a major issue, as already discussed, in both children and adults with Fabry disease. Growth was already discussed. Pain, nausea, and bloating can affect up to 70% of people with Fabry disease, maybe range from colicky pain or sudden cramping-like pain to bloating or mid-stomach discomfort, and may be triggered by meals or stress. Irregular bowel habits, so diarrhea seems to be more common than constipation can occur and may be triggered by eating, and this also seems to be related to peripheral neuropathy, the autonomic peripheral neuropathy, or changes to blood vessels going to the bowels. There's a number of questionnaires that can be completed. Also checking weight and height in children should be followed, working with a GI specialist nutritionist as needed, and then there's a range of behavioral, medical, and disease-specific supports that can be used. Some people may find that reducing caffeine, alcohol, or fatty foods or spicy foods could be helpful, and maintaining consistent meals and times. It's unclear if there's specific diets that are better, and there's a range of symptomatic treatments, whether looking at antidiarrheals, pro-motility agents, anti-reflux agents, or anti-flatulence medications that could be considered. For hearing, this was already discussed, and just want to re-emphasize that there can potentially be auditory involvement without symptoms, and so screening, at least in adults, potentially in younger individuals, should be used. This seems to be related. This is a picture of the ear. The cochlea is in blue, and the semicircular canals. There's problems with blood flow going to the inner ear, as well as the nerve itself, the cranial nerve 8. So, yeah, with that, ultimately talked about children and adults, and happy to talk more on the panel. Thanks.